Hello friends, very good evening to all of you. Today we will discuss about single injection versus double injection for costoclavicular block, and we will talk about a septum between lateral cord and medial and plus posterior cord. So we all of us know that Kumar Karmakar and team first described the ultrasound guided costoclavicular brachial plexus block, and it was like an innovation. We had supraclavicular block, we had lateral paracarotid approach in the infraclavicular region, but there were some disadvantages. Like for supraclavicular block, we needed single injection, but it was closer to the pleura and there are chances of pneumothorax. And with paracarotid approach, we were doing multiple injection technique. So advantage of in costoclavicular block initially described what was with single injection you can block all the nerves in the infraclavicular area. So it was described in literature, and if we look at the sona anatomy in the brief, infraclavicular fossa, there are two parts: median infraclavicular fossa and the lateral infraclavicular fossa. So if you look here, the medial infraclavicular fossa, it extends from the lateral border of the first rib cranially to the superior border of the pectoralis minor muscle inferiorly. So it is somewhere from here to here. And if you go in the lateral infraclavicular fossa, it lies deep to the pectoral muscle and in relation to the second part of the axillary artery. So this is the lateral infraclavicular fossa. So costoclavicular block is in the medial infraclavicular fossa, while pericarotid approach is in the lateral infraclavicular fossa. Here you can see it. This is the area we are interested in. So in costoclavicular approach, we will say how to scan. Dr. Manoj Kumar Karmakar and team described this scanning should be done in the 5 steps. So we will see one by one. So step 1 is to put the probe over the clavicle in the transverse line, in somewhere in the mid clavicular line. So here you can see this is the clavicle. Then we will move the probe little caudally. So what we see? We will see the pectoralis major muscle, we will see the subclavius muscle, we will see the axillary artery, we will see the cords lying lateral to the it, and we will see a second rib and pleura below it. So somewhere here will be the pleura, this is the artery, these are the cord. Lateral cord is the superficial most, posterior cord lies somewhat laterally and posteriorly, while medial cord lies most posteriorly. So if we go further down, we can see if we see the image in the ultrasound machine, here you can see this is the lateral part, this one is the lateral part, and this is the medial part. This is the artery, this is the vein, and these are the cords. This is pec major muscle and this is subclavius muscle. Here you can see this is pec major, subclavius, axillary vein, axillary artery. This is serratus anterior muscle, and this is the pleura. And these are the cords embedded in single sheath. So we were believing that with single injection we can block all this cord. When we go further caudally, we will see cephalic vein draining inside the subclavian or axillary part of the subclavian vein. So how it is seen, we will see here. You can see this is the cephalic vein, this is again lateral, this is median, and you can see this is artery, and cephalic vein is draining inside the vein. So if we label it, here you can see this is the cephalic vein and it is draining inside the axillary part of the subclavian vein. When we go further down, we will see the thoracoacromial artery. It will arising from the subclavian artery. So this is bifurcation of the thoracoacromial artery. So here in the image you can see these are the two thoracoacromial artery. So this is the next scan. If we go further down, little caudal and lateral, we will see the vein, artery and cords lying in the single pane. Here some somewhere here will be all three cords lying in lateral to the artery, but if we go further laterally, cords will slowly take their anatomical position lateral, posterior and medial cord. So here you can see this is the artery, these are three cords, And if we come from lateral to medial side with in-plane technique, we can inject the drug inside this sheath and block all three codes. So here is the video. We will see step by step. This is clavicle. Then we are going further down. This is subclavian artery, subclavian vein, cephalic vein draining inside the subclavian vein. As we go little down, we will see the thoracoacromial artery coming out of it. This is cephalic vein draining in subclavian vein, and here we can see these are the two divisions of the thoracoacromial artery. These are the two divisions. They are coming out of the artery. So here you can see one and second division of the thoracoacromial artery. So after looking at it, we are moving little further downward, and you can see all three cords lying lateral to the artery. So this is how we can scan for the costoclavicular approach. And this is the video of costoclavicular approach. Here this is the medial part, this is the lateral part, and my needle will come from here, and we will see how to give the block. So here you can see this is the costoclavicular subclavian artery, this is the vein, or these are all three cords lying in single sheath. Will come from lateral to medial. Here you can see my needle is coming in plane. We are targeting the space between lateral and posterior cord, and we are trying to inject the drug. But once we inject, here we are little outside, so we are piercing the sheath, and after piercing the sheath we will start injecting the drug once we are inside. So once we inject the drug, here you can see lateral cord is surrounded by drug, but posterior cord and medial cord are not bathing in the drug. So we will see how to go for it. So here you can see this somewhere here will be the septum. We'll see the septum clearly in the next video. So there was a case series published in way back in 2007 where they found that there are septa that can influence the local anesthetic spread during infraclavicular brachial plexus block. This was beginning of ultrasound era, and it was it was with I think curvilinear probe, and it was not very well seen with curvilinear probe, but they have tried to demonstrate this. Then came this study. This was published in 2020. A reliable septum exists between the lateral cord and the medial and posterior cord in the costoclavicular region, and they did it anatomically with microanatomical consideration. And the conclusion was there is intraplexus spatial septa that bundled the median and posterior cords into one compartment and separated them from the lateral cord, where they demonstrated and confirmed microanatomically. This suggests the need for two separate injection or two separate catheter placement for continuous peripheral nerve block into the superficial and deep compartment to ensure local anesthetic spread all three cords of the brachial plexus at this level. So if we want to give costoclavicular block, we need two injection. We need to inject surrounding lateral cord. Then after piercing the septum, we have to inject the drug surrounding the posterior and medial cord. And again, Manoj Karmakar and team came with higher definition ultrasound imaging, where they found peroneal sheath and fascial compartment in this area. And they defined this compartment in anterior and posterior compartment. Anterior compartment was containing the lateral cord, while posterior compartment containing the medial and posterior cord. In two cases, they found lateral and posterior cord were visualized in the anterior compartment and medial cord in the posterior compartment. So there are anatomical variation also. The peroneal sheath, septum, and the anterior and posterior compartment were visualized in 17%, 7%, 5%, and 5% of the patient. If you take it all this at the costoclavicular region before, but ultrasound visualization of this structure improves significantly after LA injection. So once you inject the drug, you will see the septum and compartment very easily. So they concluded that a single hyperechoic septum that extended laterally from the axillary artery subdivided the subperoneal compartment into anterior compartment and that contains lateral cord and posterior compartment that contains posterior and medial cords. So there are two compartments in costoclavicular region. One is anterior compartment and second is posterior compartment. Anterior compartment consists of lateral cord, while posterior compartment consists of a medial cord and posterior cord in the most of the patients. Then came the randomized control trial where they compared the anesthetic quality between singles and septum-based double injection technique with ultrasound-guided costoclavicular block, and they found that uh, onset is faster if you give a double injection, and quality of analgesia and successful block is better with a double injection technique as compared to single injection technique. And here this is the video of our patient where we gave costoclavicular block, and here you can see this is the lateral cord, these are the posterior and medial cord, and you can very well see the septum in between. So I will play the video. Here you can see we have injected the drug. This is the subclavian artery, and you can see there is a nice little bit of septum between these two compartments. If you give single injection, you will either miss lateral cord or you will miss the posterior compartment that is consisting of medial and posterior cord. So to conclude the thing, you have to go for double injection technique for costocavicular block rather than going for single injection. So if you want to give complete block and if you want a faster onset, always go for double injection technique. Locate the lateral cord, inject around it, then go for the second injection between posterior and medial cord. That will complete your block. So I hope my message is clear and loud. Thank you all of you for watching this video. Thank you very very much again.